So in today's pharmacology, we are looking at oxytocics and tocolytics. Now, when you look at oxytocics, these are agents that work like oxytocin. Oxytocin makes the uterus to contract. Therefore, the oxytocics are drugs that will be making the uterus to contract. Okay, and the drugs includes oxytocin itself and the ergot derivatives or the ergot alkaloids, including ergometrin, and also the prostaglandins E and F. When do we use oxytocics or these drugs to cause the uterus to contract? In the induction of abortion, like when the uterus, let's say you have got someone that has gotten pregnant, within the first few days or weeks, you can make the uterus to contract and then you'll be able to push out that child. Okay, so the prostaglandins, you can use them for abortion and also for the induction of labor. What happens is that when someone has reached term, so term is 37 weeks of pregnancy up to 42 weeks of pregnancy. So some women will reach term, but then the uterus is not contracting. So what happens is you are going to help them to start the contractions of the uterus so that they can give birth, because without the contraction of the uterus you can't give birth. So to help in the induction of labor, you can give prostaglandins and also oxytocin. You understand this, you'll be seeing how this happens when you go into obstetrics and gynecology. And then also augmentation of labor. Now, what's the difference between induction of labor and augmentation? Augmentation is labor has already started. Labor is basically the contractions, okay, and the pain. It has already started, but it's not strong enough for you to be able to push out the baby. So I want to strengthen those contractions. So what do? You can give oxytocin. You are going to give oxytocin, okay, to augment labor. So this is what happens. And actually, you also give oxytocin after a woman has delivered the baby. So because what happens that when the baby comes out, delivery doesn't just include the coming out of the baby. It also includes the coming out of the placenta. So when a woman gives birth, when you remove the child, you give her oxytocin in the muscle. You will use normally the vastus lateralis. You inject the oxytocin so that the uterus will be contracting so that the placenta can also come out. Because the thing is that if the placenta doesn't come out, if any segment of the placenta remains on the uterus, that is a bad thing. It can cause what we call postpartum hemorrhage, bleeding after delivery. And that's one of the biggest, it's actually the biggest cause of death in a pregnant woman after delivery. The biggest cause of death is postpartum hemorrhage. So we want to avoid that. Okay, so give also the oxytocin. So I've already explained this other one, prevention and treatment of postpartum hemorrhage. You can give the prostaglandins, oxytocin, and ergometrin. Hope that makes sense. Now, the tocolytics are drug agents that suppress. These ones are agonist. Toco is contraction. Lytic is to break or to stop. So these ones suppress uterine contractions. So they include the beta adrenergic agonists. Remember, the sympathetic nervous system will be promoting these contractions. So I mean, the parasympathetic will promote contraction. The sympathetic promotes no contraction. Okay, so it's important for you to understand that. All right. So the beta 2 adrenergic agonists suppress uterine contractions, and also magnesium sulfate. It's a very good drug you understand later on. So they are used in relation to their effect on the uterus is the suppression of premature labor. In other words, sometimes a woman can end up going in labor where the uterine contractions start happening, but the baby is not fully developed. She's not yet at term. She's below 37 weeks. So in that case, If someone goes into labor before 37 weeks, what you want to do is to give them tocolytics, okay, to stop those contractions, and then you give them dexamethasone. Dexamethasone is a corticosteroid. It helps in the development of the lungs, because the thing is that before term the lungs are not fully developed. So I'm going to give these guys tocolytics so that the baby is not born, to allow for the time for dexamethasone to work so that the lungs can mature, so that even when the child is born, at least the lungs are mature, they can breathe by their own on the outside environment. So let's start with the oxytocics, starting with oxytocin. Now, oxytocin is also named the love hormone or the cuddle chemical, okay? Because it plays an important role in bonding, in trust, and in emotional connection. So, what does oxytocin really do? It's involved in social bonding. It will be able to strengthen emotional ties between people, like between parents and children, romantic partners, or even close friends. Okay? And then oxytocin is also important in childbirth and lactation because it triggers uterine contraction during labor and helps with the ejection of milk during breastfeeding. It's also important in sexual activity. It is released during orgasm and contributes to the feeling of intimacy and satisfaction. That's why for someone that you sleep with, someone that you have sex with, you are going to be bonded with them because a lot of oxytocin is released during sexual contact. So it will be very hard for you to break free from people that you end up sleeping with. And then mood regulation also, oxytocin can be used for that. It can reduce stress and anxiety. Okay, although its effects depends on the context, it doesn't always lead to positive emotions. So the biggest ones is for bonding, helping in the contractions. So oxytocin is a hormone synthesized in the hypothalamus and it is secreted from the posterior pituitary gland. Okay, from the posterior pituitary you only have two hormones, oxytocin and antidiuretic hormone or vasopressin. So what does it do? It has got direct and indirect effects on the contraction of the uterine muscles. Directly, it can work on the smooth muscles to induce contractions, and indirectly, it can stimulate the uterine smooth muscles to make prostaglandins, which will now make the uterus to be able to contract. Okay, so you can see that oxytocin will help in the ejection of milk and also stimulate contraction and also the onset of labor. What are the medical uses of oxytocin? When it acts on the oxytocin receptors, what oxytocin is going to do, number one, it is going to be used as an oxytocic agent. It will cause contractions, okay, induction and augmentation of labor, prevention and treatment of postpartum hemorrhage. I already mentioned to say it will help you actually give it, okay, like postpartum care. You are immediately someone delivers the baby while the placenta is still inside, before you can pull out the placenta from the cord using the cord, you are going to give them oxytocin so that the uterus will be contracting to push out the placenta. Because if you pull out the placenta very quickly, we have what we call the cotyledons of the placenta. They can remain in the uterus, and when the cotyledons remain, it will cause bleeding, and I tell you, there will be bleeding. Someone will go in shock and they will die. Okay, you will just understand this one better when you go into obstetrics and gynecology. Okay, so you just don't pull out the placenta there and then, you give oxytocin every time. So what are the side effects when used as a drug? High doses can cause uterine rupture, tachycardia, and arrhythmias. And rarely it can lead to oxytocin toxicity, especially if the uterus becomes overreactive. So it's so rare to have toxicity. How about the prostaglandins? The prostaglandins will be able to bind to the prostaglandin receptors on the uterine smooth muscles and cervical tissue, and once they do that, they are going to cause the uterus to contract, and for the cervix, they cause the cervix to ripen. Okay, that, and also to soften. So for labor to happen, what happens is that the cervix is actually thick, but for labor to happen, it becomes so thin, like as like a plastic, as thin as it is, and that thinning we call it effacement. So if the cervix is not fully effaced, you might not be able to give birth. Okay, because what helps in labor, there is effacement and then dilatation. So the cervix has to dilate. Okay, it is going to soften so that it can dilate. The space, like the distance should be like 10 centimeters. Okay, because this cervix is closed, like it is 0 centimeters normally, but it's going to end up opening up to 10 centimeters for the baby to come out, and then it has to thin, very very thin. Okay, like a plain paper. So prostaglandins helps in thinning. Now, prostaglandins can help in the termination of pregnancy, in induction of labor, and also control bleeding after delivery. The side effects include nausea, vomiting, diarrhea, and also fever, especially for misoprostol. Misoprostol is the prostaglandin E1 analog, PGE1. And this one, there's also risk of uterine hyperstimulation. It can be so much stimulated. So the route of administration varies. Some can be given orally, others vaginally, others rectally. Actually, if someone is bleeding after delivery, okay, they have got postpartum hemorrhage, PPH, you are going to get misoprost and put it in the rectum. So that is the rectal misoprostol. The contraindications for prostaglandins includes women with previous uterine surgery, because these guys are causing contractions, and conditions that increase rupture risk. So you don't want to give them. What are the clinical indications for prostaglandins? Dinoprosten. So they are used in the termination of pregnancy, like abortion, medical abortion. Examples, I've got dinoproston, which is a PGE2, gameprost, which is PGE1, and misoprostol, which is PGE1, which is the most common drug when it comes to the hospital in our setting. Prostaglandins are also used for the induction of labor. Dinoprost, which is a PG2 alpha, dinoproston, and misoprostol. These can be used to induce labor, to start labor. You also have carbaprost, which is 15 methyl PG2 alpha. Please take note, this is actually PGF2 alpha. Dinoprost and the carbaprost, these guys are prostaglandin F2 alpha. Misoprost is PGE. These ones are F. Please take note. And this F2. Okay, that's important for you to know. When you come to obstetric and gynecology, they can even ask you a question. Mention any examples of common use drugs in postpartum hemorrhage. You can mention misoprost, carbaprost. Okay. And then you also have these drugs being able to be used in postpartum hemorrhage. You have got carbaprost, misoprostol. Okay. Misoprostol is often preferred because you can use it orally and also rectally, especially in low resource settings. And then you have got egometrin or egonovine. Egometrin is a potent urotonic agent. Urotonic, it will cause the uterus to contract. As you can see, the EGOT alkaloids have got different uses. You have got those used in migraine, like dihydroegotamine for migraine, that's headache. And then you have those that have got cardiovascular effects, like egotamine and the same dihydroegotamine. And then those that act specifically on the uterus, egonovine, which is egometrin, and egotamine. So egometrin is a partial agonist on alpha adrenoreceptors, dopamine, and serotonin receptors. It's a partial agonist. Partial agonist means that they can act as agonists and antagonists. Okay. So it will be able to directly stimulate the uterus muscle to increase the force and frequency of contraction. Take note, it will increase the force and frequency. So the uterus will contract more and it will be contracting more often. So it can cause a sustained uterine contraction with high doses. So the uterus like will contract and it contract for like for a long period of time it remain contracted. Okay. The indications for this ego for egometrin includes postpartum hemorrhage, PPH, and post-abortion hemorrhage. Like after an abortion, someone is bleeding. Okay, postpartum is after birth. You are bleeding. Postpartum hemorrhage. I've forgotten the word hemorrhage there. And then postpartum, post-abortion hemorrhage. The adverse effects. These guys can cause hypertension because remember they've got effects on the cardiovascular system. So they can cause the blood vessels also to contract. So that can cause those side effects. They can also cause the coronary artery spasms. Like egometrin is a vasoconstrictor, so there will be these spasms in the coronary artery, and then they can cause nausea, vomiting, headache, hallucinations, and convulsions. And then for the tocolytics, which are uterine relaxants, these are used to suppress uterine contractions and delay preterm labor. Remember, term is between 37 weeks of pregnancy and 42 weeks. Before 37 weeks, we call it preterm. So if the membrane rupture before 37 weeks, we call it preterm premature rupture of membrane, also known as PPROM. And then if you have got labor before 37 weeks, we call it preterm labor. Okay. And the problem here is that why don't we want labor to be before term? The fetus are not fully developed. The lungs are not fully developed. So the reason as well we're going to give tocolytics is to give the fetus more time so that when we give the fetus dexamethasone or the corticosteroids, the lungs can develop. And corticosteroids will work. They take a bit of time after 24 hours. That's when they start showing the effect. Okay. So the primary purpose of the tocolytics is to delay labor for 48 hours to 7 days. And the importance for that is to allow for the time for administration of corticosteroids like dexamethasone, betamethasone, so that the lungs can mature. And also for maternal transfer, so that in case labor started at a lower level facility or at home or something like that, where you can't really provide the service in case the mother is at risk of some complications, you can transfer them to a higher level facility. Okay. So tocolytics do not stop labor permanently. They only delay labor. And they are often used with corticosteroids because the corticosteroids will help improve outcomes, like help the development of the lungs. Another tocolytic of importance is magnesium sulfate. And this is very important because it will offer neuroprotection to the fetus. We'll talk about it. So what are the common tocolytics? This is important. We have got beta agonists, for example, ritodrine, salbutamol, terbutaline. How these drugs work is they will stimulate the beta 2 receptors, and that will cause the relaxation of the uterine muscles, and that will reduce the intensity and frequency of uterine contractions, and that will suppress premature labor. But remember, these guys can lead to tachycardia, hyperglycemia, and pulmonary edema. You also have calcium channel blockers. An example of a calcium channel blocker is nifedipine. How it works is that it will inhibit calcium influx. If there's no influx, it will reduce contractions. Okay, so the side effects, because there's no contraction, there will be hypotension, there can be headache and flushing. Okay, because if there's no contraction of the blood vessels, it means that the blood vessels are dilating and a lot of blood is passing there. That's why they're flushing. You also have non-steroidal anti-inflammatory drugs like indomethacin, which will inhibit prostaglandin synthesis. Remember, prostaglandins are cause contraction. So it means that if you inhibit the prostaglandin synthesis, then there's going to be now they are not working. So there's going to be tocolysis. The problem is that these guys can cause GI upset because the NSAIDs, remember, they also have an effect on the stomach. They can also cause, indomethacin specifically causes the premature ductus arteriosus closure. And that's important to know. That's why you will not normally even use it as a tocolytic. Magnesium sulfate is also another, this one is the calcium channel blocker. Okay. And how it works is that it will be able to block calcium channel and therefore relax smooth muscles. It will be able to suppress premature labor. One important thing that you need to know about magnesium sulfate is that you can actually give it to a woman that has got what we call preeclampsia. Preeclampsia is just where a woman who is greater than 20 weeks of gestation, like the pregnancy is more than 20 weeks, and then she has got a high blood pressure. So high blood pressure in pregnancy means that blood pressure is greater than 110 over 90. Okay, actually greater than 140. Yeah, we can say greater than 110 over 90. Okay, in pregnancy. Now, depending, so you can as well define. So if the blood pressure is greater than this normal value, remember the normal value for blood pressure is what is 120 somewhere there. So you define preeclampsia, high blood pressure in pregnancies, the BP is greater than 140 over 110. Then you say that someone has got a high blood pressure in pregnancy. But if this blood pressure ends up going beyond 160, okay, over 110, that is now severe. So preeclampsia is where a woman has got a high blood pressure greater than 140 over 110, greater than 20 weeks of gestation. Okay, so we have got mild and we have got severe. So the severe preeclampsia is the blood pressure is greater than 160 over 110. That's severe. So preeclampsia is very bad because it leads to poor outcome in pregnancy. The child might not be able to survive well. So for someone that has got preeclampsia, if they start developing seizures, we now say they have got eclampsia. So when you give magnesium sulfate to someone that has got high blood pressure in pregnancy, someone that has got preeclampsia, you are going to prevent them from going into eclampsia. You are going to prevent the seizures. That's the advantage of magnesium sulfate. Okay. Besides it being a tocolytic, it also prevents seizures, or it prevents the progression of preeclampsia into eclampsia. Another advantage of magnesium sulfate is that it is protective to the nervous system of the child. So we say it is neuroprotective. That's another advantage. But a problem is that magnesium sulfate can cause respiratory depression. It causes, so you need, when you give magnesium sulfate, you are going to be looking at the respiratory system, okay, like the respiratory rate, because it's a depression of the respiratory system. Another disadvantage of magnesium sulfate is that it causes a drop in urine output, oligoria. Okay, there's a problem there, a drop in urine output. So you are also going to be monitoring the urine output. Another problem is that it causes hypertonia. The reflexes are going to be exaggerated. So another thing that you'll be doing is that when you give a woman this, you also be not doing the tendon reflexes just to see if there's toxicity. Take note of those the three side effects I've mentioned: respiratory depression, hypertonia, and also urine output being disturbed. And take note of the advantages: neuroprotection, and also prevent seizures for women that have got this high blood pressure. Other drugs that act as tocolytics are the oxytocin antagonists. Remember, oxytocin itself causes contraction. So the antagonists will cause relaxation. An example is atosiban. Atosiban will block the receptors for oxytocin and so it will inhibit contractions. Okay, and it has got minimal maternal and fetal side effects. So that is it on the tocolytics and oxytocics. Some questions from exam papers. Which of the following agents can be used in the management of postpartum hemorrhage? Aspirin, carbaprost, epoprostenol, metoclopramide. We've mentioned carbaprost, which is a prostaglandin F2 alpha analog. A 25-year-old female is given dinoproston to induce labor. Which icosanoid does dinoprost represent? So dinoprost is the prostaglandin E2, isn't it? Analog. A 30-year-old primipara woman has visible vaginal bleeding within a few hours after delivering her baby. Uterine massage and the infusion of oxytocin did not control the bleeding. Upon examination, it was felt that the hemorrhage was due to uterine atony. An intramuscular injection of igometrin was given. Which of the following action most likely mediated the therapeutic effect of the drug? In other words, what's the therapeutic? What's the mechanism of action of igometrin? Selective contraction of uterine arteries, endothelin release in the uterine vascular bed, induction of powerful uterine contraction, platelet aggregation. So igometrin, this guy causes the uterus to contract, and once the uterus contracts, it's actually clamping the blood vessels. When you clamp the blood vessels, they will not be bleeding. That's how you help in this condition. After delivery, hemorrhage, postpartum hemorrhage. Okay, so the postpartum hemorrhage has got the causes of postpartum hemorrhage. We represent them by the four T's. Four T's. The first one is the atonicity. The uterus can't contract. That is the biggest cause, atonic uterus. And what can cause the uterus to be atonic includes any condition that will cause the uterus to be overly extended. For example, having too many babies, like multiple gestation. For example, having a lot of children and then having twin pregnancies, or having a lot of fluid like polyhydramnios. All these conditions will actually cause the uterus to become atonic. Another thing is trauma. Another thing is any problem with thrombin, which is basically any clotting problem. Okay, all these causes bleeding after delivery. A woman goes into premature labor with concerns about inadequate fetal lung development and the risk of fetal distress syndrome. The butylene therapy is started to slow labor. Which other adjunct should be administered prepartum specifically for the purpose of reducing the risk and complication of the newborn's immature respiratory system development? Remember, we had said to help with the lung development, you give a corticosteroid like dexamethasone. Tocolytic medications are primarily used to tocolytics to increase uterine contraction, no. Induce labor, no, because they are basically doing the opposite. Delay preterm delivery by suppressing uterine contraction, yes. Promote milk letdown, no. What causes milk to come out is actually the uh, oxytocics. Which of the following is not commonly used tocolytic agent? Tocolytic, remember, beta-2 agonists, magnesium sulfate, oxytocin, calcium channel blockers. Now, oxytocin is not a tocolytic, it's an oxytocic, so it's out. Which tocolytic is commonly used in preeclampsia for fetal neuroprotection? So remember we said magnesium sulfate. What is nifedipine? It is a calcium channel antagonist. How about indomethacin? It is an NSAID. Debutylene, it is a beta-2 antagonist. Oxytocin is released by which gland? Adrenal gland, pancreas, posterior pituitary, hypothalamus. So the oxytocin comes from posterior pituitary. It's actually produced in the hypothalamus. The posterior pituitary only stores it. Okay. A key indication for tocolysis is postpartum hemorrhage. In postpartum hemorrhage, you don't give tocolytics. Instead, we give these guys that will help in contraction, okay, which are the oxytocics. And then preterm labor, yes, you give tocolytics because you want to have time for the child to be able to develop the lungs. Uterine involution, breast engorgement. Oxytocin can be used to induce ovulation, not ovulation unless if it was labor. Increase blood pressure, that's not the use. Reduce bleeding after childbirth, that's true postpartum hemorrhage. Treat type 2 diabetes, really not. While tocolytics can delay delivery, their most crucial role is prevent all premature births. That's not true. They don't prevent premature births. Improve fetal outcome directly. It's not even direct, all right? Allow time for antenatal corticosteroid administration to improve fetal lung maturity. Yes. Reduce the need for C-section. Yes. Okay. Which of the following is a primary use of oxytocin? To induce labor and augmentation of labor. That's true, isn't it? To delay preterm labor. Now, it doesn't delay. If you give oxytocin, to actually cause it. To manage uterine atony and postpartum hemorrhage, and we explained that's true, isn't it? So it's A and C. And then I've got a diagram here for you to match. Which one direct stimulates the uterus to induce or augment labor? So direct stimulates the uterus to induce or augment labor. Oxytocin does a good job there. It may be used to terminate pregnancy, induce labor, or manage postpartum hemorrhage if agometrine fails to control postpartum hemorrhage. So those are prostaglandins. If you just hear of termination pregnancy, that is prostaglandins. Calcium antagonist tocolytic that can stop seizures in eclampsia but requires close monitoring in renal function. It is also used in severe and controlled asthma or Tessed's de Pointes ventricular arrhythmia. So that one is magnesium sulfate. Management of postpartum and post-abortion hemorrhage. We had mentioned the egometrin there. So that is it for this class. I hope we've gotten a good understanding of these drugs.